if you can take the time to understand this one page, this one paragraph, it basically takes you from zero to completion on the major concepts of fatty acid therapy. And then, I talk about doses.
I'm an old soul, got a funky sound. Gonna sing a song, turn the world around.
Hello, everybody. Dr. Alex Vasquez coming to you live right now to talk about fatty acids. And this past week, I wrote a brand new introduction to the concept and the whole topic of fatty acid supplementation. And I think and I hope that I've gotten everything essential in that conversation down to one paragraph that fits on one page. And so, in order to help make this accessible to everybody who has found themselves in my audience, I'm going to take the time to read this right now for a couple different reasons. But the ultimate reason, of course, is that I want this information to be accessible and understandable by everybody who might benefit from it, whether you're a doctor or a patient. And the reason I feel like this is important, or I judge that this is important, is because even if you've studied, in undergraduate school, for example, even if you've taken a class in organic chemistry and physiology and biology and things like that, you still may have never been exposed to this type of vocabulary. So, and if you didn't study, biology or something like that in college, then the chances of you having been exposed to this vocabulary in such a way that actually helps you understand it is probably close to zero. So, you can see conversations about fatty acids floating around and flying around everywhere. But I think that unless you've had the terminology explained to you, then a lot of the concepts remain elusive. So exactly 20 years ago, in 2004, the later part of that year, and then in the early part of 2005, I published 2 articles detailing at the highest possible and practical level of detail that I could muster. I published an article in 2004 talking about fatty acid biochemistry, and then in 2005, I followed up that article with a part 2, which was on the clinical applications of fatty acid therapy. And I had studied, obviously basic and clinical nutrition in chiropractic college, and then again in naturopathic medical school with Alan Gaby as my nutrition professor, and he's undeniably one of the world's international experts in nutrition. So I graduated from naturopathic medical school, Bastyr University, in September of 1999. And even though I was educated in nutrition and fatty acids, the level of science just didn't exist back then. Obviously, relative to what we have right now. So we have a lot more insight, we have a lot more vocabulary, and we can go off the deep end with all that vocabulary. And I did do that a little bit in the monograph that I wrote back in '04 and '05, and then a lot of that information I just copied and pasted directly into everyone's favorite book, which is Inflammation Mastery, 4th edition. And you can see here that I give a lot of space to talking about the terminology and biochemistry of fatty acids, starting on page 358. So starting on that page, I basically walk you through all the fatty acids in the omega-3 class and then the omega-6 class. And as I'll talk about in this paragraph that I'm about to read, you can see that a lot of the fatty acids, for example, in the omega-3 class, they interconvert one to the other. So we start with alpha-linolenic acid, and then we eventually work our way down here to icosapentaenoic acid and then docosahexaenoic acid here. So, again, I want everybody in my audience to have that basic vocabulary. And so since I had, condensed all that information down to one page and basically one paragraph, I would like to think that this serves as a good summary and reference point for us to use in moving from, for some people, a state of not knowing anything about this at all to actually, by the end of that same paragraph, within one page, you can start from pretty much ignorance. And then at the end of that page, you know more than most medical doctors about fatty acids. That's the goal, and I think that's a reasonable. I mean, it's a lofty goal. I'll read this to you in just a moment. We'll see if we achieved that. If I achieved that. So again, the information in the book goes through the omega-3 fatty acids. Then I talk about the omega-6 fatty acids, and most of the omega-6 fatty acids are bad. That's why I've colored them here in red, except for these two in the middle, which are the good omega-6 fatty acids. So when we talk about omega-6 fatty acids, I'll define that terminology here in just a moment. But in this class of fatty acids called omega-6 fatty acids, we start with plant sources, and that's linoleic acid, like you would get from corn oil and canola oil and other seed oils. Linoleic acid, omega-6 fatty acid, and it's bad. That promotes cancer development, especially breast cancer and colon cancer. That gets converted into another omega-6 fatty acid called GLA, which is also found in plants like borage oil and hemp oil, and that's a good fatty acid. So, in the omega-3 fatty acids, they're all good. But in the omega-6 fatty acids, it starts bad and then gets good. That's why I colored it green. And then we go back to red, which is my color for danger, because GLA gets converted into DGLA, and then that gets converted into arachidonic acid, which also promotes inflammation and cancer growth. So the omega-6 fatty acids are a little more complicated. Again, we start with linoleic acid from plants and seed oils. That gets converted into a health-promoting, anti-inflammatory, anti-cancer fatty acid called GLA, or gamma-linolenic acid. The active metabolite of that is dihomo-gamma-linolenic acid. So it's DGLA, dihomo-gamma-linolenic acid. And then that gets converted into arachidonic acid. And arachidonic acid is what gets converted into all these inflammatory prostaglandins down here, which promote pain, inflammation, and tumor growth. So, like I said, 20 years ago, I published what at that time, and to my knowledge, was the most comprehensive review article ever published. And I'm not just making that up when I say that. I mean, so that was 2004, 2005. So I was 5 years out of school, having studied with, a bunch of naturopathic experts, and also Alan Gaby in clinical and basic nutrition. So, I was certainly well trained in nutrition, and on top of that, I was, devouring research and writing books and writing articles. And I just never saw a really good article that summarized the biochemistry and the clinical applications of fatty acids. So I had to write the article myself, and that's what I did. And that's how I, gained this level of knowledge and expertise on this topic, is because I worked to develop that knowledge and expertise. I read everything I could find. I wrote the article, and I had it reviewed by a few nutrition professors, just to make sure that, I was on task, so to speak, because fatty acid biochemistry can be somewhat complex and certainly intimidating, especially, writing out all the flow charts and the interconversions and all this kind of stuff. So, like I said, I want everybody to be able to understand this information, but I also respect the fact that it's complicated. I respect the fact that the vocabulary is unique. Even if you've studied organic chemistry, you may have never heard these terms. And even if you went to medical school, you would have probably never heard most of these terms. So, I went to medical school starting in 2006 to 2010. And medical school is basically the task of, and this is true in chiropractic and naturopathic schools as well, but I guess for me it was a little more potent and intense in medical school because the stakes were much higher and everything was just more intense. So in all programs, but again, it was just more intense in medical school, osteopathic medical school. You've got your core classwork and your requirements and all the hoops that a person has to jump through, and that's a lot of hoops. And it's almost death-defying, the level of intensity of it. I mean, it's just incredible. Even for somebody like me who's pretty academic. I felt like I was like running in the Olympics every day of 4 years of medical school. But parallel to the experience of medical school is you also, a medical student always has to be thinking about, passing the board exams. USMLE is the medical board exam, and then the osteopathic doctors have their own medical licensing exams. And I did both. And I did very well on those exams for medical licensure in the United States. I did the medical ones, the allopathic ones, the MD ones, and I also did the DO ones. And I scored, in the top 1% and the top 5% on those exams. But my point is, throughout the intensity of medical school and throughout the intensity of having to study for, medical licensing exams, I never saw any of this mentioned. So again, the point is, a person can graduate from medical school, a person can get licensed as a medical doctor in the United States, and still never see this vocabulary and never get these concepts. And these are important concepts. So, for me, fatty acid metabolism is a bit basic, but that's because I understand it and I know it. That doesn't make it less important just because it's, falls within the category of kind of basic nutrition and clinical nutrition. In fact, the fact that it's somewhat basic actually, in a sense, underscores its importance because, the basics are what support anything else on top of those basics. Like your house has to have a cement slab foundation or a pier and beam foundation, whatever. But, you think of your house as being, windows and walls and pictures and furniture and your memories and all that kind of stuff. Well, none of that would exist if the basic foundation of your house wasn't strong enough to support the rest of your house. So, like I've said before, through all my studying in whatever, even in high school, I've mentioned this before, but I had a physics teacher who, appropriately so, he really, drilled home, the basics. And I mentioned this in one of my conference presentations. One of the things he said is, if you take care of the numbers will take care of you. And, what he taught us, and it's somewhat instinctive and obvious, but still needs to be said, and that is, you have to take care of the basic fundamentals in order to ever get to something more advanced. Unless you're going to be, a typical American allopathic medical doctor and then just skip all the basic stuff and then just go to advanced. And that's what the medical profession does. They ignore the importance of basic nutrition, biochemistry, and physiology so that they can then do whatever the hell they want with drugs and electroconvulsive therapy and anti-migraine drugs that don't even work for 85% of patients, and these rheumatologic drugs that cost $50,000-$80,000 per year. The anti-migraine drugs cost $7,000 a year, but they only work in 1 out of 6 patients. So in order to get one patient better with the new class of anti-migraine drugs, the CGRP drugs, for example, I just posted this yesterday and I just wrote it this week. In order to get one patient better from a drug that costs $7,000 per year, but only works in 14% of patients, which means it has an 85% failure rate, you have to spend $42,000 as a country, as a society, as an insurance program or whatever. One of those systems, or out of pocket, the social context would have to pay $42,000 just to help one patient with the most advanced anti-migraine drugs on the market. That's pathetic. So, and obviously I've talked about migraine in this book, Inflammation Mastery. I am making a few updates to that protocol, and any updates that I make to that protocol, I'll publish online in the videos. But I'm telling you now, I already know where the conversation's going, and it's not going to change anything. So, I encourage you, especially if you're a doctor, if you're a doctor, you should have this book because, first of all, it's a business expense. You're not even going to know that you spent the money. But if you're, seeing patients in whatever setting, especially if you're, in a cash practice like I was for however many years, then, you make more money by being better at your job. And the way you get better is by going to conferences and also buying books. So here's the section on migraine. And like I said, I am making updates to this. I'm going to post the updates on the website. But I'm telling you again, it's not going to change anything. Here's the section on migraine, cluster, and other headaches. Cluster headache, in my opinion, is just a variant of migraine. Obviously they have a lot of superficial differences, but the basic biochemistry is the same. So I'm updating this information, and I already know it's not going to change anything. It might change like one thing. So I'll just make a video about that and put it on the website. But especially if you're a clinician, I encourage you to buy this book. It's got all the biochemistry, basic nutrition, and the most important clinical protocols. That includes, a basic foundational nutrition plan that I've also published several times. And one of the components of that 5-component plan is fatty acid therapy, and I'm going to read that to you right now. So let's all sit back and light a candle or whatever. And here we go with going from zero to completion in one paragraph on one page, trying to summarize everything important about fatty acids. I'll try not to interrupt myself because I've already read this now 3 times. I think it's good enough. But here we go. Fatty acid supplementation and my version of fatty acid supplementation, which is combination fatty acid therapy. Human physiology requires the external provision and dietary intake of fats and oils that contain subcomponents of fatty acids in the omega-3 class and the omega-6 class. These are categorized based on the location of an unsaturated carbon-to-carbon bond when counted from the methyl or omega end of the hydrocarbon chain. Stay with me. And you may have to read this more than once in order to get it. Like if this is totally new to you, I wouldn't expect anybody to say, oh wow, it's the omega end of the hydrocarbon chain, of course. Just try to work with me here and just try to be exposed to the information on the first pass, and then on the second pass, you'll pick up a few more. And then if you read it a third time, you'll start to say, oh, well, I can maybe get some of this. Or maybe you get it the first time, or maybe you already know it. But again, I'm just trying to introduce what I consider to be the most important concepts. Yeah, so basically you've got 2 categories of essential fatty acids. They're called essential because it's essential that you get them from the diet. That's why they're called essential fatty acids. They're in the omega-3 class or the omega-6 class. Those are kind of parallel classes, and they don't interconverse. So omega-3 is always omega-3, omega-6 is always omega-6. And it's just based on the structure and the location of the first unsaturated bond between 2 carbons. But that little bitty, itsy-bitsy structural difference in the hydrocarbon chain, that little difference makes all the difference in the world in the biochemistry and therefore the physiology and therefore the life and death difference of fatty acids. This apparently minor structural detail in biochemistry translates into huge differences in the physiologic effects of omega-3 versus omega-6 fatty acids, and is therefore of clinical importance, especially in the prevention and treatment of inflammatory metabolic diseases. Believe it or not, that was all one sentence. Because the prehistoric and pre-industrial diet of humans contained about 7 grams per day of omega-3 fatty acids, human physiology became dependent on this regular provision. In today's setting of a relative or absolute deficiency of omega-3 fatty acids, because now people only get 1 gram per day, whereas pre-industrially or prehistorically people got 7 grams per day, we commonly find clinical benefit in omega-3 fatty acid supplementation to restore the prehistoric or pre-industrial omega-3 fatty acid intake. And for this reason, we use flaxseed oil, for example, or walnut oil, because those contain the omega-3 fatty acid, alpha-linolenic acid, or ALA, or the more powerful and potent sources of omega-3 fatty acids are fish oil, containing the more powerful biologically active omega-3 fatty acids that are EPA and DHA. And you can live a very happy life thinking to yourself about EPA and DHA from fish oil. You don't have to know how to pronounce them, but I'm going to show you how to pronounce those words, just so you know. But you can be very happy and very competent and very comfortable and confident just saying EPA and DHA. But the way that those words are pronounced, the first one is icosapentaenoic acid, and the other one is docosahexaenoic acid. And again, that's just EPA and DHA. Given that the omega-3 fatty acids are generally anti-inflammatory as well as cardioprotective, anti-diabetic, and anti-cancer, and that the omega-6 fatty acids are generally pro-inflammatory and pro-cancer and pro-diabetes and pro-psychopathy, the modern misanthropic shifting of the absolute and relative amounts of these fatty acids in the human diet by reducing omega-3 fatty acids and increasing omega-6 fatty acids has changed the previous ratio of about 1-to-1 or 1-to-2, meaning 1 unit of omega-3 fatty acids for every 1 or 2 units of omega-6 fatty acids, to the current ratio of approximately 1-to-25. So again, omega-3 and omega-6 fatty acids in a prehistoric or pre-industrial diet should be relatively balanced at 1-to-1 ratio or a 1-to-2 ratio. But now the ratio is 1-to-25. So that basically screws up virtually the entirety of human physiology. And this has greatly, albeit almost invisibly, contributed to the increased prevalences of inflammatory, malignant, metabolic, and mental diseases. That's like 3 sentences. But we're almost finished. We're almost halfway through that paragraph. We can accurately generalize that the omega-3 fatty acids, alpha-linolenic acid, icosapentaenoic acid, so that's ALA, EPA, and DHA, docosahexaenoic acid. We can accurately generalize that those omega-3 fatty acids are anti-inflammatory and health-promoting via various mechanisms, including maintaining and improving cell membrane function, prostaglandin formation and balance, and gene expression. We could say other things like mitochondrial function and changing the gut microbiome and things like that. Those are important. Maybe I'll add that later, but this is where we are right now. And that these anti-inflammatory benefits are clinically important, commonly at the same levels of effectiveness as pharmaceutical drugs, yet with greater safety, better affordability, and numerous collateral benefits. So that was well said, if I may say so, and very accurate. So, for example, in the treatment of migraine headaches, according to some of the most recent research, fish oil is twice as effective as anti-migraine pharmaceutical drugs. Twice as effective in reducing migraine days per month, specifically. Now, the cost of those anti-migraine drugs, this is just going to be kind of a global survey of concepts without too much math. But to receive the benefit of fish oil in the treatment of migraine headaches for over the course of a year would cost approximately $300. So $30 a month. I'm just ballparking that number. We could probably do it for cheaper than that, but let's just say $30 a month. That would reduce the headache burden for a migraine patient by approximately 4 or 5 days per month, which is about 60 days per year. I mean, that's a lot. That's 2 months of being migraine free. in comparison to the anti-CGRP drugs, which cost $7,000 a year and only reduce migraine burden by 2 days per month. I mean, that's a stunning difference. Fish oil reduces the burden by 4 days per month for about $300 a year, and the drugs reduce the burden of migraine by 2 days per month, but cost $7,000 a year. I mean, that's just huge. Plus, like I mentioned in this paragraph, what's the expected collateral benefit from the anti-CGRP drugs? Nothing, zero, no benefit, not that I've ever seen. What's the expected benefit of using fish oil in the treatment of migraine headaches? Well, better alleviation of migraine headaches for one, but also reductions in depression, anxiety, joint pain, back pain, cardiovascular risk, reduced risk of diabetes as well. So, as I said before, with nutritional therapy, we commonly see an abundance of collateral benefits. Whereas with drugs, because drugs focus only on one pathway at a time, they can't provide the abundance of collateral benefits that we see with nutritional supplements because those function throughout the whole body. So, numerous collateral benefits. The omega-6 fatty acids, linoleic acid, abbreviated as LA, from grain, seed, and corn oil, and arachidonic acid, mostly from animal sources, well, exclusively from animal sources, from land animal sources. These are clearly pro-inflammatory in addition to promoting cancer and tumor growth, disordered metabolism, altered gene expression, and generally promoting a diseased phenotype. Sorry, I'm just going to make a few changes here. Minor changes. As such, got about 3 sentences left, but my sentences are long, as you know. As such, a commonly employed anti-inflammatory strategy by nutrition-knowledgeable clinicians is that of reducing omega-6 intake via dietary modification while increasing omega-3 intake via supplementation. The exception to the rule, and the rule is that omega-6 fatty acids are pro-inflammatory, is that of gamma-linolenic acid, GLA, and its active metabolite, dihomo-gamma-linolenic acid, which is DGLA, which is both anti-inflammatory and anti-cancer, anti-tumor. GLA is an intermediate metabolite, as I showed you in the diagram. GLA is an intermediate between linoleic acid, LA, and arachidonic acid, and is prevented from conversion to arachidonic acid by the provision or supplementation, I'll say, just to make it a little more redundant, of EPA and DHA from fish oil. More precisely, one of the enzymes, delta-5 desaturase, that converts GLA to ARA, arachidonic acid, is inhibited by EPA and DHA from fish oil, mostly EPA. So I'm going to take out the DHA, because I don't think that's correct. Because the unsaturated carbon-carbon bonds in omega-3 and omega-6 polyunsaturated fatty acids are vulnerable to oxidation and can thus drain available antioxidants from closed systems, including the many patients with marginal nutritional antioxidant status, accompanying the supplementation of polyunsaturated fatty acids with additional fat-soluble antioxidants, especially vitamin E, roughly 400 to 800 international units per day in the form of mixed tocopherols with approximately 40% gamma tocopherol, is physiologically reasonable and clinically advantageous. So, the two main things that I just said there are, you want to reduce the intake of omega-6 fatty acids and increase the intake of omega-3 fatty acids in order to get better inflammatory balance or anti-inflammatory balance throughout your whole body. And because, the second thing that I just said right now, because those fatty acids are unsaturated, what that means from an organic chemistry standpoint is that they're vulnerable to oxidation. And so you have to protect them with antioxidants. And, you know, the go-to antioxidant for protecting fats and oils is vitamin E. Now, as I've said before, when we talk about vitamin E, we can say vitamin E, but it's an okay thing to say, but at a higher level of analysis, it becomes kind of it's not really the right thing to say at a higher level. The reason for that is that vitamin E is a family of different compounds. So when we talk about vitamin D, for example, we're pretty much talking about vitamin D3, cholecalciferol. No debate about that. I mean, unless somebody wants to talk about vitamin D2, which is totally stupid. It's not even a human nutrient. So, but when we talk about vitamin E, we are ultimately talking about a family of different compounds. Alpha tocopherol, DL tocopherol if you want. I mean, that's synthetic garbage. Gamma tocopherol, which is the best form of vitamin E. If you had to pick just one, I guess you'd go with gamma tocopherol. And then, to the side of the tocopherols, you have a whole other family called tocotrienols, which are also anti-inflammatory and analgesic, and they provide a lot of benefits. So basically what I'm saying here is that in order to protect the fatty acid therapy that we're trying to implement with more omega-3s and fewer of the omega-6s, we have to protect those fatty acids with more antioxidants. And vitamin E is the prototype. And you can tell I'm old school because I said 400 to 800 international units. That's the old way of measuring vitamin E. But that's also what most of the research, that's the unit used by most of the research. I think maybe the newer units are micrograms, but I don't really care because I still think in terms of international units because most of the research quantified vitamin E in terms of international units, and so those are the units that I default to without doing the conversion to micrograms or whatever, or milligrams, even though the numbers come out somewhat similar. Again, when we talk about vitamin E, one of the forms of vitamin E is called gamma tocopherol, and that gives you more advantage. So if you're reading a label, you want to look for gamma tocopherol. And you would like for it to be around 40%. Again, this is physiologically reasonable and clinically advantageous because vitamin E itself is also anti-inflammatory. Subspecies, so here's my second part of that sentence, subspecies of vitamin E, such as tocotrienols and gamma tocopherol, are anti-inflammatory, thereby providing additional or synergistic benefit to polyunsaturated fatty acid supplementation. So I'm just going to write N3 there because that's exactly what I'm talking about. Maybe with GLA. Yeah, I'll add GLA there too, just to be clear. Final sentence, I believe, is the following. Because of the valuable clinical benefits of fatty acid supplementation and the need to supplement with each of the most important anti-inflammatory fatty acids, again, those are ALA, EPA, DHA, GLA, and oleic acid from olive oil. Oleic acid is an omega-9 fatty acid. It's called monounsaturated. It's not polyunsaturated. It only has one unsaturated carbon-to-carbon bond, supposedly. At the 9th carbon, that's why it's an omega-9 fatty acid. But it's also anti-inflammatory. This provides optimal clinical benefit, and I have described this approach as CFAT, or combination fatty acid therapy, and I've discussed that in some of my publications, also, of course, in the book, because the publications, I just copied and pasted them right into the book, basically. And then, of course, I had more space in the book so I could go into more detail. And then I also did a video for my graduate students many years ago, and I've posted that on the website as well. So if you can take the time to understand this one page, this one paragraph, it basically takes you from zero to completion on the major concepts of fatty acid therapy. And then, I talk about doses in other places. But I mean, the dosage for adults is really simple. The combined amount of EPA and DHA per day for an adult to get legitimate benefits is 2 to 3 grams per day. It's actually, the minimum dose is 1.9 grams per day of EPA with DHA. That will optimize the vast majority of people over the course of a few months. Obviously you could use a higher dose, kind of as a loading dose if you want to get there faster, like of course I do. And the minimal therapeutic dose for GLA, which is the omega-6 fatty acid that I mentioned here, the minimal therapeutic dose there is 500 milligrams. So, I mean, here in one page, I just basically told you everything that you need to know on a practical level about fatty acids. Why we do it, how to do it right, justification for it. And just now, verbally, I told you the doses. Maybe I'll add the dose to this paragraph just to make it completely solid. But again, for EPA and DHA, the omega-3 fatty acids, you want about 2 grams per day. If you want to be more aggressive, you could do 3 grams. I've used 13 grams a day in some cases. And for GLA, at least 500 milligrams per day. And you can go higher than that. But 500 is certainly reasonable and certainly effective for most conditions. So that's it. I mean, that's everything basically that you need to know about fatty acids in one page. And so I'll finish recording this video right now and get this on the website, and hopefully this will work for some of you as a way to, you know, whatever works for you. To not feel intimidated by the vocabulary, to feel comfortable talking about these things. Even if you're a patient, you know, this hopefully will advance your knowledge and confidence in using this intervention, which I think is hugely important and foundational and should be part of the treatment plan for just about everybody. And if you're a doctor or nurse practitioner or PA or anybody else, then I still think this is a very competent review. So hopefully you got some benefit out of this. I'll wrap it up and get this on the website as soon as I can. Thank you very much. This has been Dr. Alex Vasquez, again from inflammationmastery.com. Current and upcoming editions of the protocols. I'm not going to rewrite everything, but I'll make a few updates, and when I do make updates or summaries like this page, then I'll give you the walkthrough on the website in video format. So thank you very much. Have a good weekend. Take care. Bye.
I'm an old soul, got a funky sound. Gonna sing a song, turn the world around. I whoop that ass, you know I got the moves. Spank that ass, I'm gonna make you move. I ain't no player, I'm just here to shake. Hop that ass, no time for heartbreak. I'm the one who brings the rhythm to the night. I keep you dancing till the morning.